What if everything that you've been told about losing weight after you hit perimenopause and or menopause is actually making it harder? Like when your doctor says you don't qualify for GLP-1 medications like Ozempic or Mounjaro because you're not obese or diabetic, or that you just need to eat less and move more. Because here's what the research shows, and nobody's talking about this. Women gain 2 to 14% more body fat during this menopause transition. And that transition starts in perimenopause, sometimes years before your period actually stops. And here's the part that should make you angry. 4 to 14% of that fat is visceral fat, belly fat, the dangerous kind that wraps around your organs. And this doesn't happen because you're getting older. See, studies show that these changes occur independent of aging. They're specifically linked to estrogen deficiency, which begins during perimenopause and actually accelerates that loss throughout the entire menopause period. Your hormones changed, your body changed, and nobody gave you a new playbook. So you did what anybody else would do. You tried harder, you cut more calories, you added more cardio, and it stopped working. Or even worse, it backfired. I'm Dr. Jones, DC, and I lead the coaching department for a nationwide GLP-1 and peptide clinic, and I've worked side by side with women's healthcare practitioners for the last decade. We've prescribed hormone therapy in every form that you can think of: pellets, injections, creams, troches, and I've coached thousands of women through optimizing their health during perimenopause and postmenopause. This isn't just professional for me. You see, I lost 100 pounds myself, and I know what it feels like when your body stops responding to the things that used to work. And I've seen the same frustrations in women that I coach, doing everything right, watching the scale go in the wrong direction no matter what they tried. So in this video, I'm going to show you why the try harder approach is just failing you, and it's not your fault. I'm going to break down the hormonal shift that's actually driving weight gain during this stage of life, and I'll give you the framework that works with your new biology instead of against it. You see, this isn't about working harder. Of course you got to work harder, but a lot of you are. It's about working smarter. And by the end of this video, you're going to understand exactly why that matters, whether you're in perimenopause, menopause, or beyond. So let me show you what's really going on. Here's what I see all the time. A woman comes in, usually in her mid-40s to early 50s, and she's done everything right. She's cutting her calories, she's increased her workouts, and maybe she's already on a GLP-1 medication, but she's stuck. Or worse, she's freaking gaining weight. And here's her instinct. Let's try harder, cut more calories, move more, push through the barriers. But the research actually shows something important here. And this is the part that should change everything for you. You see, what we see in our clinic is that perimenopause, menopausal women often have reduced insulin sensitivity compared to premenopausal women, even at similar ages and weights, showing the direct connection to this hormonal shift. The research shows this pattern, though some of it may be driven by the visceral fat redistribution that we talked about earlier. This belly fat right here, this fat right here ended up being around your belly as you shifted into menopause. See, either way, different hormones, different metabolic picture. And it gets worse. Your FSH levels, that's the hormone that rises during perimenopause and menopause, actually correlates with worsening insulin resistance that's independent of your body weight. So you could be doing everything right and still gaining because of what's happening hormonally. See, this isn't willpower, this isn't discipline, this is biology. Let me tell you about Lisa, because I think this will resonate with you. She's 48, business owner. She came to me after losing 40 pounds, eating 1,200 calories a day. Sounds like a win, right? Then she hit a wall. 6 weeks, nothing. Scale wouldn't budge. Her instinct, more cardio, higher medication dose, try harder. But when I talked to her, see, here's what I heard. She was exhausted, brain foggy, freezing cold all the time, even indoors, constipated, her body was achy. See, her body was screaming at her to stop, and she wanted to push through that. There's that tough mindset there, right? Her body had gone into what I call battery saving mode, aka starvation mode, aka zombie mode. When you undereat for a long time, your metabolism downregulates to protect you. See, it thinks that there's a famine, so it slows everything down. Now, by the way, if this is hitting home for you, if you're realizing that your body might be stuck in that same battery saving mode, we offer discovery calls where our patient advocates can actually assess your specific situations and help you understand what's actually happening metabolically. You can either text the number on the screen or you can check that link in the description if you want to explore that. But first, let me show you what we did for Lisa. We did the opposite of what she expected. We increased her calories slowly over a 3 to 6 week period, up to 2,000. She lost 2 pounds during the reset and then 15 more after. Easier, not harder. Let me show you why this happens. The hormonal shift that's driving all of it. So what's actually happening inside your body during perimenopause and menopause? Why does fat suddenly start piling on, especially around your belly, even when nothing else changed? It comes down to a key player here, estrogen, and more specifically, what happens when estrogen levels drop. You see, you have estrogen receptors in your fat tissue. They're called ER alpha and ER beta. And these receptors do something really important. They actually regulate where fat gets stored and how the fat cells grow and how easily you can burn that fat. When estrogen is present, it promotes subcutaneous fat. That's the fat tissue that's underneath your skin, the safer fat. And it actually inhibits visceral fat, the dangerous belly fat that wraps around your organs. But when estrogen levels drop, that protection disappears. Your body shifts from storing fat in safe places to packing it around your midsection. This is why so many women tell me their body shape just completely changed during menopause, even when the scale didn't move that much. And here's where it gets worse. When you lose estrogen's anti-inflammatory effects, your visceral fat tissue starts pumping out inflammatory chemicals. And this inflammation drives insulin resistance. So think of it like this. Calories are the gas in your car, but insulin, that's the key. And if insulin is too high, if you're insulin resistant, it doesn't matter how little gas you put into the car. The car is locked. The fat is locked. Your body can't access this fat for fuel. And it gets even more frustrating because estrogen also influences the hypothalamus. That's the appetite control center in the brain. When estrogen levels drop, hunger signals, they go up. Fullness signals go down. You store more fat easily and it goes straight to your belly. This is why the whole eat less, move more, it feels impossible during this stage of life. You see, you're not fighting a calorie problem. You're fighting a hormonal problem. If you're finally understanding why nothing else has been working, hit that subscribe button right now because I put out 4 videos per week on hormonal weight loss, GLP-1 optimization, peptide strategies, and specifically what works for women during these stages of their life, perimenopause, menopause. And it totally helps out the channel big time, so go ahead and hit that button right now. Now let me show you how big this problem really is. And the statistics back this up. The prevalence of metabolic syndrome. That's the combination of insulin resistance, belly fat, visceral fat, high blood pressure, abnormal cholesterol, jumps to 30 to 50% in postmenopausal women. This isn't rare. This is common. Now I'm going to go much deeper into the insulin resistance and perimenopause in an upcoming video. I have a whole menopausal series that's going to be coming out through the next 8 weeks with 1 video per week. Now, while aging contributes to metabolic decline, the menopausal transition accelerates these changes through estrogen withdrawal. This isn't just getting older. This is a specific hormonal shift that requires a specific response. And that's exactly what I'm going to give you. A framework that works with your new hormonal reality, not against it. So let me show you what this looks like. If the problem is hormonal, the solution has to be hormonal, not just eating less, not just moving more. We need a framework that addresses what's actually happening in your body. And here's what that looks like in our clinic. I'm going to walk you through the whole complete solution stack, and I want you to understand why each piece matters, especially during perimenopause and menopause. Number 1, strategic fasting. Now, you might have heard that fasting is bad for women during menopause, that it stresses your hormones out, that it'll backfire. But here's what the research actually shows. A 2020 study specifically looked at alternate day fasting and compared results by sex and menopausal status. And the finding? No significant difference in weight loss outcomes between premenopausal and postmenopausal women. Both groups lost 4 to 6 kilograms over 8 weeks. Fasting alone isn't the problem. Fasting without structure, without proper refeeding, without protecting your muscles, that's the problem. See, we use something called the flow protocol. This has been my strategic approach that I've developed through the decades. Strategic fasting that works with your insulin patterns, not against them. When done correctly, this will help break insulin resistance without triggering that battery saving mode that we talked about earlier. Number 2, GLP-1 medications like Ozempic, Mounjaro. These are powerful tools. In clinical trials, tirzepatide, that's Mounjaro or Zepbound, produce 15 to 22% weight loss over 72 weeks. And here's something important. 60 to 70% of the participants in those trials were women, many of them in their 40s and 50s. But here's how I think about these medications. They're powerful tools, not permanent solutions. They'll control appetite and they'll improve insulin sensitivity while you do the deeper work of fixing your metabolism. For most patients that I coach, the goal is optimization now and reducing the dose over time. Now, for this whole menopausal series, if you want me to make a video in the upcoming weeks about specifically optimizing your medication doses during perimenopause and menopause, let me know in the comments where you're at and if that'll be helpful to you. Number 3, fat mobilization. This is where one of my favorite peptides comes into play, AOD 9604. See, providers are working with AOD for stubborn menopausal belly fat. That's visceral fat that won't budge, even when everything else is working. The mechanisms make sense. It's based on growth hormone biology, but it's not growth hormone. And it may help you mobilize fat from those resistant areas. Now, large-scale human trials are still limited, but the clinical observations that we're seeing in patients are very strategic and encouraging. Patients who I coach are reporting visible changes in those stubborn areas when we add AOD to the protocol. Now, pillars 4 through 6 are where most people go wrong. Pillar number 5, by the way, is non-negotiable. Okay, number 4, hormonal foundation. This is bioidentical hormone replacement therapy, meaning your hormones that match what your natural body used to produce. Estrogen, progesterone, and sometimes testosterone can be part of the foundation for some women. We talked about what happens when estrogen levels drop. In the right candidates, replacing it might help improve insulin sensitivity and support metabolic function. But here's what I tell every woman that I work with. When HRT helps, it's still not the complete solution alone. Results are going to vary, and you still need the other pillars. Think of it as one piece of the foundation, but not the whole house. Number 5, and this one is non-negotiable, protein and resistance training. I'm going to say it again, protein and resistance training. You got to get enough protein. You got to do enough resistance training. I'm going to go deeper on this in a minute here because this is so important, but I want you to hear me say it now. Without adequate protein and resistance training, no protocol will work optimally during menopause. None. And number 6, professional guidance. Look, I'm giving you the framework in this video, laying it out for you. But menopause adds complexity. Perimenopause versus postmenopause timing, it matters. Medication interactions matter. Your individual hormone profile, it matters. What works for a 30-year-old isn't going to work likely for you. Unless you're 30. That's why you'll want to work with a healthcare provider who understands menopause. And honestly, that's why I do what I do, because cookie cutter protocol approaches fail during this stage of life. Now, if you want me to make a video in the upcoming menopause series, specifically about menopause, premenopause, and the differences in the fasting and weight training protocols that we do, or maybe if you have an autoimmune condition and how that affects your menopause, let me know in the comments if that would be helpful to you. Now, finally, the last pillar, professional guidance. It brings me to a story that changed how I coach. Let me tell you about Jessica. Jessica, 43, she lost 35 pounds on her protocol. Sounds like a win, right? Then we did a DEXA scan. That's a body composition test that shows exactly how much fat versus muscle you have on your body. 15 of those 35 pounds was muscle. Understand that both of these represent 1 pound. 1 pound. But look at the size difference, almost twice as big. She didn't lose all the fat that she thought. All that muscle loss, that's 750 calories of metabolism. Finito gonzo. Every single day, her body now burns 750 fewer calories than it did before. She lost weight, but she set herself up for regain and rebound. She thought she'd rebuild the muscle later. But during menopause, you can't afford to lose it in the first place. Menopause already causes muscle loss. It causes this medical condition called sarcopenia, aka muscle loss. And if your weight loss protocol accelerates that, you're digging a hole that you might not ever climb out. So here are the 2 non-negotiables. Resistance training. I need you doing this 3 times per week, 45 minutes. This is not optional during menopause. This is critical for muscle preservation and bone health and maintaining your metabolic rate. I don't care if you've never lifted a weight in your life before. We all got to start somewhere. And speaking of bones, postmenopausal women, especially Caucasian women, have the highest rates of menopause. And guess what? One of the best things to do for strengthening the bones is lifting weights. So you get a double whammy. Your muscles and your bones benefit. Second is protein intake. In our clinic, we target 1 gram of protein per pound of target body weight. Now, this is higher than standard recommendations, but here's why. If your goal weight is 150 pounds, you're aiming for 150 grams of protein. This is aggressive compared to typical guidelines, but during menopause, especially on GLP-1s, we find patients need that intentional focus to preserve muscle and actually ensure that they hit the goal. I would rather you overshoot your protein than undershoot it. The challenge is that these medications suppress your appetite, which makes hitting that target hard. You have to be intentional about it. It has to be distributed across your meals. I had a teacher, Susan, she was only getting 40 grams of protein a day because the medication killed her appetite. Her hair was falling out in clumps by second period. She couldn't focus enough to even grade papers. The medication was working, but she was starving her body of what it needed. Without these 2 foundations, protein and resistance training, no protocol will work optimally. Not fasting, not GLP-1s, not peptides, none of it. You'll get short-term results. You think you'll be tricked into the long-term game, And then you're going to find out when you do that DEXA scan or body composition scan that you lost your muscle, and it's just a matter of time before you rebound. These aren't optional add-ons. These are foundations that everything else is built on. So here's the thing. I just gave you a lot of information, and you might be thinking, okay, I'll just do this myself. Fasting, protein, resistance training, talk to my doctor about getting on a GLP-1, and you can absolutely start there. But here's what I want you to understand about this stage of life. Menopause adds complexity that generic advice can't address. Are you in perimenopause or post-menopause? Because the timing of the interventions matter. Research shows there's a window of opportunity for hormone therapy. Starting it earlier produces a different metabolic benefit than starting it later. What medications are you currently on? How do they act with GLP-1s or with the fasting protocols? What does your individual hormone panel look like? Does your doctor say that you don't need thyroid therapy, but you got tiredness, brain fog, constipation, feeling cold, hair loss, your body's achy, brittle skin and nails? Those are thyroid symptoms. What works for a 30-year-old woman isn't going to work the same for you. Again, unless you're 30. And what works for your friend in menopause might not be what works for you either, because her hormone profile, her biology, her history, her metabolism are different from yours. This is why cookie cutter approaches fail during this stage of life. And honestly, it's why I do what I do. Now drop a comment telling me what you've already tried for menopausal weight loss, the diets, the workouts, maybe even the medications, and I'll tell you what pattern that I'm seeing and what likely is missing, the kind of protocols that we give to our patients. So let's bring this home and what you can start doing today. Number one, stop blaming yourself. This isn't a willpower problem. This is a hormonal shift. And now you understand why. Number two, audit your protein. Are you hitting 1 gram per pound of target body weight? If you're on a GLP-1 medication and you're not tracking this, I guarantee that you're falling short. 3, start resistance training. Even if it's body weight exercises at home 2 to 3 times per week, protect that muscle mass for crying out loud. And 4, stop trying to out-diet your hormones. If you've been stuck at eating 1,200 calories and wondering why nothing's working, now you know. Your body needs a metabolic reset, not more restriction. Now, this video is going to be one in a series of multiple weekly menopausal videos that I'm making specifically for you. Here's what to expect in the upcoming weeks. In the next video, I'm going to go much deeper on the estrogen insulin mechanism, why menopause causes weight gain at a cellular level, and exactly what's happening inside your fat cells. If you want the full science, that one's for you. After that, I have a complete video coming specifically on optimizing GLP-1s for menopausal women, because the standard protocols, they don't account for what's actually happening hormonally speaking. Then I'll be doing a myth busting video on everything that you've been told about menopausal weight loss that's just flat out wrong. Make sure you're subscribed so that you don't miss any of those videos. Now, if you're dealing with stubborn belly fat that won't budge, fatigue that's wrecking you for days, or you've tried multiple approaches and nothing's sticking, that's exactly why we offer these free discovery calls. You'll get a chance to speak to one of our patient advocates who will take the time to get to know you, go through your history, what you've already tried, and your long-term goals. You'll get a feel for what it's like to work with me, my women's healthcare practitioners, our coaches, the whole shebang. And they'll walk through the programs and pricing so that you can see what long-term success actually looks like. You can either text the number on the screen or check out that link in the description if you want to explore that. Now, if you're wondering about the diet side of things and what you should have stocked up on your fridge, you need to check out this video right here. These are the 20 base groceries that I think every woman and man, quite frankly, should have stocked in their fridge for healthy eating. Check that video out, guys, and I'll see you later.